Additionally, important things to remember, echo sessions are interactive learning communities, so please leave your webcam on and have a microphone available when possible. This is especially important during the breakout groups at the end of the session, as we'll have an opportunity for discussion. And also throughout the entire session, please use the chat function if you need assistance or have any questions. We're more than happy to answer those or respond to them if you have questions during the presentation itself. Finally, please consider renaming your profile with your first and last name as well as your organization so we know where folks are from. Those are the instructions, pretty self-explanatory. Just hover over, click the three dots and click rename. And I will then hand it off to Dr. Jennifer Hellady. Jennifer Hellady, excuse me. Dr. Jennifer Hellady is a researcher and faculty here at the University of Minnesota with focuses in early intervention and outreach. And I just want to welcome Dr. Jennifer Hellady.
Thank you, Drake. Thank you for that nice introduction. Welcome, everyone. It is so good to see all of you. It is a beautiful day in Minnesota. And I'm just happy, hopefully some of you are taking this outside, but I'm just happy that you're here and you've taken some time to listen. I think our content is going to be very good today. Just to quickly review, it looks like most of you have been on before, but this is Minnesota Project SCOPE. For those of you that are new, what SCOPE stands for is supporting children of the opioid epidemic. We focus on neonatal abstinence syndrome or neonatal opioid withdrawal syndrome now, so you may hear terms such as NAS and NOWS. We're a community of early intervention providers supporting children and families, and we use the ECHO virtual training model. Next slide, please. Again, we reviewed this every week, so many of you know this by heart, but ECHO stands for Extension for Community Health Outcomes. We work to promote health equity, share knowledge and expertise. Our goal is really to reduce disparities and increase access across the state of Minnesota, bridging healthcare and education systems. Next slide. Again, for our principles, we use technology. We use best practices to reduce disparity. We always have a case or family stories. In medical world, they say case study, we say family story. In the educational world, and we use data to monitor outcomes. And one way we use data is we ask you to fill out the evaluation at the end so you can get your credit for attending, and then we can have data on what you liked about the presentation and how we can improve. This is session 7, Provider Strategies for Continuity of Care with Dr. Lynne Katz. Next slide. And here is our schedule for the day. We're starting with welcome and intros. I'll switch it over to Dr. Katz for the presentation. We'll do our family story breakout groups, come back, and we'll get you out of here promptly by 4 p.m. Next slide. So I have the opportunity to introduce our speaker for today, Dr. Lynne Katz, who's a research associate professor in the departments of psychology, pediatrics, and the School of Education at the University of Miami. Dr. Katz is the former director of the University of Miami's Linda Ray Intervention Center. Dr. Katz, I am happy to read your much longer bio. If you like, would you like me to, or would you like me to put it in the chat? I just want to give you plenty of time.
Let's put it in the chat.
Okay.
People can review it.
Yes, I will put in the chat because you've done so many wonderful things, but I want to give you plenty of time so we can hear about it. Thanks, Dr. Katz. I'll turn it over to you.
Thank you. Thank you, Jen. So glad to be with you all today. And there's a certain irony in the fact that you stated it's a beautiful day in Minnesota, because in fact, what it is today here is the tail of a tropical storm. I'm in the Miami, Florida area, and it is pouring and flooding. So I'd rather be there with you guys. So nice to be here. Our topic today is really focused on all of you who deliver early intervention. And I just want you to know at the start of this, that's who I am. I'm an early intervention person for close to 30 years, although I wear a number of different hats. And I get to travel to places such as you can see here, the Twin Cities. The last time we visited the Twin Cities to work with the juvenile court there was a pleasure. And so we get to take information about our program outcomes and strategies that work all over the country. So I've been the director until a few months ago of an early intervention center specifically designed for babies born prenatally drug exposed. And that goes back as far as the 1990s. We've been looking at that. So as you all know, drugs of choice have changed over time. In those days, we were talking about exposure to cocaine, maternal use of cocaine. Over the years, we've moved through methamphetamines, and now we're adding opioids to the issues, and our community has dealt with all of those. So just like yourselves, we're in what we call an early steps provider. What does that mean? Our goal is to deliver Part C services to infants who meet eligibility under Part C for developmental delays. In Florida, we do not have an at-risk category, which is very interesting. So being at risk due to what's going on in your family does not enable you to get into early intervention. You literally have to be evaluated and meet the criteria for developmental delay. So as you all may have experienced or not, when a child, an infant comes into a family where there is identified drug exposure and drug use, what happens is there's a connection with child welfare. You may call it DIFAS in your community. We call it the Department of Children and Families. And the folks who work in that system of care have the same goals for successful outcomes for families as we do. But the fact is we speak a very different language. Our terminology is very different. How we get to where we want to go for outcomes for children and families, we may have different paths. But the fact is we need to learn how to work together so we can bring all of our resources to the table. So what do we mean by continuity of care for this discussion today? I like to define it in this way. Continuity of care for our infants and toddlers in Part C and their families in a very holistic way, to me means what are the strategies and approaches that are most likely going to support retention of the child and the family in that program. And for our sake at the Linda Ray Center, we wanted to engage that child and family for the first 3 years of life, as long as the child continued to meet criteria for Part C. So we spent many decades working on different strategies and approaches. But what we wanted to see was how could we best work interagency? How could we cooperate? How could we learn the language of what each of us were doing who come into the lives of these families and provide a seamless continuity of intervention across our disciplines? The other thing I think that's very important is we were in a university setting. So everything we were doing, I'll use the phrase evidence-informed research strategies. We wanted to show over the decades what it is that really worked for families and which families it worked for. We were in Miami as a culturally and linguistically diverse community, and the same with social status in terms of economics and communities. And so it's vastly divergent, all in one setting. And we wanted to know, do our interventions work? What does that mean? Which interventions that we were doing to engage families and work with children had the best chance of improving the expected developmental outcomes for the children who were in our program by the time they reached age 3. Now, there's just some interesting things I'm just going to throw out very quickly. The fact is that when you look at the literature, what do I mean? When you read the research about early intervention, people are doing early intervention all over the world, all over the country. And more than 90% of the programs that are out there have no evidentiary support at all that what they're doing works for children, or which children it works for, which families it works for which children does it not work. And we've known this for decades, but in many communities, we don't inform ourselves with our assessment data or our evaluation data to say, are we helping children and families to the best that we can? And if we are not, what do we need to tweak? What do we need to change? So sort of looking at what we're doing. But when you try in a community to change the way that people do business, and you don't have science or research involved in what you're doing, somebody, Leonardo da Vinci, we've heard of him, he once said that those who practice without any science impact are like a pilot who goes into a ship without a rudder or a compass and really never has any uncertainty where he's going, or if he's gotten there, or if he got there in the best way he or she could. So we know a number of things about children who are drug exposed, and we've had that data and information since the late 1990s. We know that children who are prenatally exposed to a drug are at risk for cognitive, language, and behavioral delays. Doesn't always happen, but they're at great risk for that, and we need to be cognizant. And so when we were designing our program, I said to myself, or inside my brain, our staff has to be better than good, because we are compensating in our partnership with families. So often we're compensating for some of the disconnects that the children have already experienced in infancy and up until age 3 before we saw them, due to no fault of their own, but due to the experience and the coexisting risk factors that go on if your family is impacted by substance abuse. So we also wanted to see if we could retain children who came in as babies. Could we retain them in our program all the way to age 36 months? And could we reduce their need for Part B services? So could we do enough for those children and their families and teach their families how to best support them so that they literally graduated at 36 months and went into regular, typically developing preschool environments? That was one of our goals. Okay, so the Linda Ray Center Birth to 2 program, we're part of Miami-Dade, Florida's public schools pre-K program for children with disabilities. We're an early steps provider. I don't know if that's what you call Part C, but that's what we do in our state. And we want to keep in mind that at the time we enrolled these children, the criteria was 100% of them had to meet eligibility with developmental delay for Part C. And for our program, the only one in Miami-Dade County, there also had to be a validation that there was exposure to drugs. So that could be a parent report, it could be a DCF report, a mother reporting that she had used, the hospital doing testing of the newborn. Any of those things would help them meet criteria. And so we would enroll them as infants and try as much as we could to keep them in our program for 36 months. And what we know, as I just said, and you all know that as well, if there's a risk factor of drug use in your home and in your family, there's a risk of child maltreatment very often due to the status of the primary caregiver who's using drugs or under the influence. And often the parents have limited parenting skills, not because they can't be good parents, but because they will self-report, I've never parented any of my children sober. So I don't really know what good parenting is. I've done my best, but I know I've been in and out because of my substance use. So we were a combination of early intervention, direct services, and in our program, we served 60 babies at any one time, followed those 60 babies for 3 years to the best that we could. Okay, so in the early years, in the 1990s, what we did was we assigned the babies that were referred to us to a center-based program, which was 25 hours a week, coming to the Linda Ray Center 5 days a week from 9 until 2, or they got randomly assigned to our home visitation program, 3 hours of in-home intervention from an early interventionist, or they were referred to the medical model only, where they had a pediatrician and a nurse practitioner in their lives, but no teacher. So if you've ever studied research, one might say that that third group was a control group, but we don't use that term because they were followed pediatric wise. based on any of the risks that came from the substance exposure. And they learned about developmental support from their pediatrician or their nurse practitioner. And so those were the first 3 levels of intervention that we provided. Multiple groups of children that came with us as babies and stayed with us till age 3 in the first 10 years of the program were in one of those 3 groups. And then we looked at the outcomes. Now, let's think to ourselves. Do you think that children did better who were in a center-based program for 25 hours a week, or a home visitation program, 3 hours a week, or referral for pediatric surveillance, what we call it, and medical assistance? Well, we didn't go in with any suppositions, but we looked at the data at 36 months after multiple groups of children went through our program. And the children in the center-based program closed more of their developmental delays and were more typically on target at 36 months than the children who got 3 hours of home visitation or just medical treatment. Now, when you're a scientist, you can choose to do one of 2 things. Well, let's keep going along this route. Give the children, some children more intervention, some children less, some medical surveillance. But we use that information to inform our practice. And we said to ourselves, why would we continue to do just home visitation? Why would we continue to do just primary medical care? The functionality of the center-based program is the most effective to having children be where they need to be at 36 months. So let's have all the new babies come into the center. Let's give them the medical support. Let's give them a nurse practitioner on site. And let's have home visitation as part of what we're doing so they can have and their family support at home. So I guess you could say we merged the 3. We didn't just keep people in intervention dosages that weren't doing what we wanted. Okay, next slide. Okay, just another factor here that we all need to take into account. And we know this because when we write individual family support plans in Part C, they have the word family in them for a reason, because the family needs to be engaged with us and be an equal participant. But a lot of times as early intervention folks, we don't really realize the barriers that the parents of our children are facing if they have issues with substance abuse. And so we sort of looked at some of the risk factors nationally that the family system faces. These are just some of what a child in a family system may face. It might be a family where there's low social support, family has trouble paying basic necessities, they may or may not be at the federal poverty level. Family members may have untreated coexisting mental health issues besides substance abuse. And the highest aspect is poor parenting skills, again, not based on inability to parent, but having had no experience or role models or being sober with their other children. And so now they needed to learn appropriate parenting skills and be engaged in those. And so early intervention, we think of ourselves as, how did the child test? What are the areas of delay? What do we need to do to try to support that child and have the family help us bring the child up in that gross motor area or that fine motor area? But let's think about everything encompassed in that family system when there's drug use, and realize we need our community providers to partner with us to help with the whole package if we're going to be successful. Next. And then I think that this is just an important slide, because we know that when we are developing as children, there's stress in our lives that needs to be there, and we need to learn how to respond to it. In other words, it could be something like, how long is the baby crying before somebody responds to that baby's and understands they're hungry, they need something. So moderate stress takes place in children's development as it is. But if you're in a family where the adults are dealing with a lot of other issues and they're seeking treatment and they're seeking support, sometimes your needs are less met than in other situations. And we have to keep in mind that the more stress you are under as a baby, as an infant, as a toddler, the more you have to overcome. So I'm an early interventionist and I need to understand the stress that this infant and toddler may be in, maybe even at the time I evaluate that child. And how valid is the evaluation I do at Part C if the child is very stressed out time of day, whenever you're doing your evals and your assessments? And is that a true picture? Is the child really developmentally delayed, or is the child's behavior and inability to show what they know based on other factors that are going on in that child's life? This is just a quick picture. If you look at this, this is Miami-Dade County in Florida. All the red areas are high crime, low resource neighborhoods. These are from where we draw our children's referrals. And we are that tiny little blue star at the bottom. So if anybody says, well, did you help families that were in the most need? My answer to them is we sure do. We sure do. Those who have had often little access, some of their other children were never picked up for early intervention support and find themselves in special ed for years. And also these are areas of high crime and coexisting drug use. And we wanted to be where we needed to be for convenience, geographically, and to be able to serve the families who need us most. Okay, so watching my time, essential elements of our model. What is it we do and what did we learn? I told you before, typically children in our program enrolled as infants, and we strive to keep them into the program if they continue to have a need until age 3. The children are assigned to age appropriate classrooms, nurseries, call them what you will, in a center-based program with a high adult-child ratio, 1 to 3, 1 to 4. So you might have a classroom that has 12 babies in it, has 4 teachers, so that individual needs are met quickly, and the adult early interventionists, folks can divide the groups into small groups and give children individual attention. The teachers in our program have to have a degree in education, psychology, early childhood. We developed our own curriculum in our pilot that engages parents so they know what we're working on in the classroom. And our program is 5 days a week, 12 months a year. Okay, next. The home visitation aspect of what we do, an early interventionist teacher paired with an infant mental health counselor are the team that go in and visit a family as needed up to 2 times a week for an hour and a half per visit for a total of 3 hours. By the way, the research tells us that for home visitation, anything less than 3 hours of dosage of home visitation to a family is ineffective and not going to get you to some of the outcomes you want to get to. So visiting for an hour once a week is less effective and helpful to a family than what we do 3 hours a week. Okay, let's go. So what did we learn? And I highlighted some of the strategies we learned over time that I want to pass on to all of you. All right, engagement, not with a ring, but with a family. Engagement, you need to have team members who are culturally and linguistically competent to be able to engage with families where they are, meeting the family where the family is, resisting being too clinical. I can't tell you the first time a grandmother came to an IFSP meeting and somebody at the meeting said that the area of delay for the baby was gross motor. Well, the word gross means a lot of different things to different people. And the interventionist really didn't describe what gross motor meant, large muscles. The grandmother took offense. She thought it had to do with the quality of her care of the child. So we have to resist not defining the terminology we use when we're engaging families. We need to take a step back and hear their stories and let them concretely say, what do they want for their child? Sometimes that, even in an IFSP meeting, we're so busy saying the speech language pathologist tells their finding, the PT or the OT tells their findings, and the family is just like deer in the headlight. And if you ask them what happened when they leave, they just sort of look at the papers, the copies of the IFSP, and nobody asks them what they want. Well, nobody asked them, I want my child to be able to say more words. We've got space on the IFSP, but oftentimes it doesn't get enough attention. Now, the other thing we wanted to say is that, and you probably know this, good intervention works when it's based on relationships. The trusting relationship that your team creates with that family. The child is the focus, but children exist in their relationships with the adults in their families and with their teachers. And we must see children, the caregiver-child relationship, as paramount to our success. Paramount to our success. And as early interventionists in the classroom, if we're that person, that other healthy attachment figure, we need to have good attendance. We need to come to school every day. We need to be there for that child, regardless of what's going on at home, and give them the patience and the time they need for those 5 hours a day they come to visit us. A very famous psychologist, Dr. Winnicott, said decades ago, it was shocking. He said, "There's no such thing as a baby." That's what he said in quotes. There's no such thing as a baby. And people went, "Oh, don't be ridiculous. What do you mean there's no such thing as a baby?" But what he meant was, as a psychologist, babies, toddlers, children live in relationships. They reflect who takes care of them, the kind of care that they get, the way people respond to them. And we must see our young children in early intervention as holistically part of families. And we want to be role models of what healthy attachment and responsivity looks like. I know a lot of times I used to go to our classrooms and sort of gather information about teacher-child interactions, which are so important. And if I saw a teacher who was spending child time doing lesson plans or spending child time working on something that was not related to that child that was tugging on her leg, that wanted attention, I knew that child wasn't getting what they needed. All those other housekeeping tasks can wait. The 5 hours those children are with you, or the 1 hour for OT or PT, it's their time, and we need to give it to them. Another thing we all had to learn about was what we call attunement. The dance between the rhythm of each individual child's personality and temperament, and our temperament as an early intervention person, and our rhythm, and how do we come together to make a really good dance with give and take and expectations that can be met. Family-centered, concrete supports must be built. And I like to say, at our center, the classroom that the baby starts in as an infant remains their classroom for 3 years. The classroom changes, the materials change, the cribs go out, the cots come in, the little kitchen comes in for dramatic play when they're old enough, but they're in the same room. And to the degree that we can keep them, they have the same 4 teachers for 3 years. Continuity of care, because I don't know what's happening in their home life. I don't know if their mom is in and out of the picture. I don't know if they've gone into foster care. I don't know what's going on, but you should see the sigh of relief that a child coming into the classroom that is predictable with the same familiar faces it gives you such a lift that we've made that part of our model, and we feel that much of our success has to do with that. So I just wanted to say basically one last thing, and that is, so how did the kids do at the Linda Ray Center? I mean, what does your data show? Now, what we know is that young children with that whole package of risks and developmental delays who are not discovered until age 3 or age 5, we know they have a higher incidence of needing special education services. I also know of the 5 intervention programs that we have in Miami-Dade County, we're the only ones who serve children born drug exposed, that the other programs have a high rate of children who finish Part C and just transition to Part B. So they're doing a lot of Part C to Part B transitions. This is one of the cohorts we've looked at, a group of children, 121 of them, that came through our program. And instead of close to 100% going from Part C to Part B, 60% of our children at 3 years old were enrolled directly into early Head Start, and they didn't need any speech, language, any other special ed services. 60%, 6 out of 10 children. Some of the children went into Head Start, they needed speech therapy, but they were in a typically developing classroom. They were not in special ed. And the remaining children, not 100%, not 90%. So for us, the 60% who went in needing no services during that period, plus those who just needed speech therapy, 79%, is a lot more promising than 90% of the children almost automatically going to Part B. Okay, next. I just wanted to show you, this is a picture of sort of what we call our model in Miami-Dade County. So what we have is on the orange peg, we have interventions, early intervention. On the systems integration side, we've taught judges and guardian ad litems and everybody who works with the court about children with special needs. And we've taught them about putting the needs of the child first, even in their courtroom, even in child welfare. And so we feel that this collaboration with those applicable themes that I told you about help preserve child well-being, improve outcomes at 3 years old, and help children be more safe and be more healthy at age 3. I don't have all the answers, but we keep asking all the right questions. We think, what else could we do? What do we need to change? And so that's who we are. That's what we've done. Those are the lessons learned. So I think we're ready now to go on to our family story slides, if we can. Okay, just very quickly, this is just to reiterate what I said before. We worked across different agencies. We developed protocols for early intervention to know what's going on in child welfare. We have a holistic approach, family-centered, responsive both culturally and linguistically, and we're looking to engage everybody, biological families, adoptive families, grandparents raising grandchildren in our model. Okay, these are just one more time to tell you: engagement, attunement support for building parent-child relationships, even when mom is in recovery, relationship-based practices, family-centered, and learning about each other's disciplines. So we know the language and we share those disciplines with parents. Next slide. Okay, here's the family story. Nathan and Caroline, here we go quickly. The setting is Miami, Florida, a large culturally and linguistically diverse metropolitan city. The children who were referred to us were siblings: Nathan, 6 months old, and Carolina, 2.5 years old. They were referred by DCF, by child welfare, to us. We can do their developmental assessments. We're a multidisciplinary team. And the story was that the maternal grandmother had contacted Department of Children and Families when the mother, who had a substance abuse issue, left the children with the grandmother and didn't return after 4 days. Grandma didn't know what to do. We're in Miami-Dade County. The maternal grandmother was a Spanish speaker predominantly. She had very little English. And she told our social worker, that the children's mother had become addicted to painkillers before they came from Cuba, where she was working in a factory and she was hurt on the job and painkillers were prescribed to her. So they came to the US. Their legal status was a bit iffy. And then the grandmother called DCF and said, what do I do with these children? My daughter hasn't come to pick them up. So we have an infant and a toddler. And you know the immediate needs. Grandma had nothing for those children. She had no clothing, she had no bedding, she had no cribs. She didn't know how to get baby formula or how to get, in Miami, in the state of Florida, you can get relative caregiver money if you're the custodian, you're a grandmother. And there was a lot of things that they needed to do. A social worker was assigned to the family. Our early intervention team scheduled assessments for both children, and we had that initial IFSP staffing date. We had to identify, if we could, other families to bring them to the table to help offer social support to mom. Next slide. So one of the things we noticed at the beginning was Nathan appeared to be failure to thrive. He had difficulty feeding. He couldn't self-soothe. He was very tight, hypertonic in terms of his muscles, crying all the time. And grandma wasn't even sure how many drugs mom had used during her pregnancy. Okay, Carolina, she wasn't communicating verbally at all. She didn't seem to follow verbal instructions. She had a very flat affect on her face. She didn't seem to have any interest in toys or manipulatives. She didn't make eye contact, and we weren't quite sure about her hearing. She also had terrible tooth decay that had not been attended to when she was 2.5 years old. Okay, what were our challenges? The grandmother was distrustful of experts in general, and we were part of a university, and most of her fears were related to immigration issues. She was afraid that her legal status, which was kind of iffy, would keep her from getting services. She needed medical attention herself. She was pretty frail. Her housing arrangement was going to have to be modified if the children were going to stay with her. And she told our social worker, I haven't cared for very young children in a very long time. I want to be their caregiver. I want to help my daughter, but I need a lot of help. And so we had to proceed with caution and think about the best ways to communicate with her. Here are her strengths. What a lovely grandma she was. Loving, hugging the children. She appeared to be very patient, and she wanted her daughter to get better. She didn't know how that was going to happen, but she really believed that if her daughter could get healthy, the children belonged with her helping out. Her home was well organized, clean and neat, but the space had to be repurposed so she could keep the children. And we thought it was really important that she wanted to support her daughter getting into treatment if we could find her daughter, who had not yet come to claim the children. And the grandmother was very active in her church as potential support. So questions for your team as we go into our breakout teams. If you had a case like this, how would you approach it? How do you divide and prioritize all the needs of each of the family members? How do you do it in your system of care as early intervention providers? And how do you reach out to other providers in your community that you may never have worked with before to introduce them to what you do in early intervention, find out what they do, and see how you can put all of your resources together for this family? Okay. I think
All right.
that's-
Thank you,
think-
Dr. Katz. I think I did paste all the details into chat so that you'll have them during breakout. Drake, are we ready to put them into a 7-minute breakout?
Yeah, we can get them going here in just a minute. Give me about 10 seconds here.
Okay. Does anyone have any clarifying questions while we wait?
You know, Rebecca, I was watching the chat. It looks like there were a few just around the
Oh,
citation or what you talked about, Dr. Katz, in terms of the dosage effect around family home visiting and at least 3 hours, I believe. Which research study was that? Because I'd love to look at it as well. And then some people were just comparing it to Minnesota, you know, what our standard, which is interesting.
Yes, okay. The first early intervention program that had any data was called the Infant Toddler Development Program. It was actually done at 2 sites almost 30 years ago in California at UCLA and in Miami-Dade County. What I would love to do is to be able to send, it was called IHDP. And it was really one of the first early intervention studies that said what works, what level of dosage can be most helpful, and also what are your outcomes? What are you hoping to achieve? I would love, the IHDP project is a seminal research on early intervention. It talks about all of these aspects. I would like to be able to, for the folks in the chat room, send you that citation when we get off and you can spread it out to them. It's basically the whole idea of how early intervention is effective. And it's sort of groundbreaking, and it's the foundation for the work we all do, and we don't even know that we're using their data.
Thank you.
that's awesome. Well, I appreciate you, Dr. Katz. I'm glad you're going to stick around for the debriefing.
Sure.
But let's send everybody to breakouts for 7 minutes.
All right, everyone should have been invited. Feel free to join those as you see the message. Thanks, everyone.